Hello everyone, hope you're all doing great. In this video, we are going to discuss about preterm labor. See, preterm labor is one of the leading cause of infant death. Okay. So, it is the leading direct cause. Okay, that is important. Direct cause of neonatal death worldwide. Okay, worldwide this is the important cause. Around 16% causes of neonatal death are due to preterm labor. Okay, and then it is also the second most common cause for death in children less than 5 years of age group. Clear? So, this is the importance of preterm labor. So, we have to learn what is preterm labor, what are the investigations we have to do, how to prevent it and how to manage it if it happens. Okay? Right. We will see the definition for preterm labor. So, preterm labor means there is starting of the uterine contractions before the term gestational age itself. So, for this you have to know what is term and what is preterm. Okay? So, the cutoff usually is kept around 13 weeks of gestational age. So, anytime before this we call as preterm and after this we will be calling it as a term labor. Clear? So, this preterm is again classified into 3 categories. Okay? So, that is between 32 to 37 weeks and then 28 to 32 weeks and then before 28 weeks. Clear? So, this will be known as late preterm, this will be known as very preterm and less than 28 weeks will be known as extremely preterm. Right? So, term gestational age, term labor means that is happening between 37 weeks to 41 weeks. Clear? And anything after this, starting from after 42 weeks, it will be known as post-term labor. Clear? So, what does labor means? Labor means there is uterine contractions, okay, that will be sufficient in frequency as well as intensity. So, that means you will be having in 20 minutes you will have around 4 contractions, okay, and in 1 hour, that is 60 minutes, you will have around 8 uterine contractions. Okay. Not only uterine contractions, remember that this should be accompanied with cervical changes also. That is cervical effacement and dilatation also, and this dilatation should be at least 2 centimeter. Clear? So, remember the babies, those who are born preterm, that is before 37 weeks, can be small for gestational age babies or large for gestational age babies, but they will be called as preterm. Clear? Yes? Will come up again. So, term means it is 37 to 41 weeks. So, anything before 37 weeks is preterm. Again, it is divided into extreme preterm, late preterm and very preterm, right? So, when we come correctly before preterm, that is 32 to 37 weeks, it is known as a late preterm. 28 to 32 weeks, it is known as very preterm, and anything before 28 weeks, it is known as extreme preterm. Clear? And when you call this as a postterm pregnancy, above 42 weeks. Okay? And remember, this is the definition for preterm. Labor definition is there should be uterine contractions with sufficient intensity and frequency that will be associated with cervical changes like effacement and dilatation. Dilatation should be at least 2 cm, and remember the uterine contraction should be 4 contractions in 20 minutes and 8 contractions in 60 minutes. Clear? Yes. Now we will see about the risk factors for preterm labor. So, risk factors for preterm labor. See, the most important risk factor for preterm labor is a history of prior preterm labor. Okay? Then, any cases where there is uterine overdistension. Okay? Can you think about any causes where the uterus will be overdistended? Yes? Yes, it can be overdistended in a case of polyhydramnios, or yes, very good, in a case of multifetal pregnancy, and then also when there are some associated fibroids seen. Accepted? Yes. So, these are some of the causes of uterine overdistension. And then in cases where there is cervical dysfunction, or when there are infections, then even in some genetic factors or periodontal disease, then some of the lifestyle factors, then maternal fetal stress conditions. Clear? So, these are some of the risk factors for preterm labor. Understood? Yes. Now, we will see in detail about these risk factors. Okay. So, first one is prior preterm labor. So, as I said before, this is one of the most important cause. Okay. Most important cause of preterm labor. Then, the risk is threefold greater than those had a term labor prior. So, can you understand? So, if her first pregnancy was a term labor, then her current pregnancy ending up as a preterm labor is less. But when the first pregnancy was also preterm labor, then there is a threefold increase in the risk that this pregnancy will also end up as a preterm labor. Clear? Next is uterine overdistension. So, I said some of the causes for uterine overdistension, but what is going to happen in uterine overdistension? See, there is an increased expression of contraction associated proteins, okay, where in the myometrium. Clear? So, these proteins or receptors include oxytocin receptors or the gap junction proteins. Okay? And also in these cases there is an early activation of the placental fetal endocrine cascade. Clear? Right. Now, we will pass on to the next one, that is cervical dysfunction. So, in this cervical dysfunction of the epithelium of the cervix or the stromal extracellular matrix is seen. Clear? See, because this epithelial barrier is important to prevent any ascending infection. Okay? Suppose if epithelial barrier is blocked means, then what happens? There is a colonization of organisms, especially the group B streptococcus, and also there is decreased level of hyaluronate. Okay. So, these factors increase the chances of preterm birth. Clear? So, we will see about infections. See, infections are the cause for preterm labor in 25 to 40% of the cases. Clear? So, infections can get intrauterine access, okay, via 3 routes. First route is through the transplacental transfer, okay. Any maternal infection that is present, the organisms will be passed through the placental route and it will be affecting the fetus. Transplacental transfer, and then there can be infection that is coming through the fallopian tubes, okay, because we have osteo opening into the abdominal cavity, and then there can be ascending infection also, in which the bacteria will be reaching through the vagina and the cervix to the uterus. Clear? And among these routes, ascending infection route is the most important route. Clear? Yes. Now, inflammation that is happening in the absence of any detectable microorganisms. Okay. So, that will be known as, yes, sterile intraamniotic infection. Clear? Now, we have bacterial vaginosis. What is bacterial vaginosis? Yes, normal flora bacteria, that is lactobacillus, is replaced with anaerobes. Okay. So, this is also considered as an increased risk for preterm labor. Okay. Also, remember the fact that COVID-19 preterm labor was done only for maternal indications. Okay. COVID-19 as such, it wasn't a cause of preterm labor. Yes, right. And the next one you have to know is about the inflammatory response. See, when there is lipopolysaccharides or any other toxins are released from bacteria, okay, that will be leading to recognition by the toll-like receptors that is present in the decidual cells, trophoblast, cervical epithelia, and also your mononuclear phagocytes. Yes. So, this will lead to activation of the toll-like receptor and a signaling cascade will be activated. Okay. Now, what happens when the signaling cascade is activated? This is going to produce interleukins. Okay. So, you will have interleukin 8, which is a chemokine. Okay. And also you will have the cytokines, namely the interleukin 6, TNF alpha, okay, and you have so many other things also, okay, like extracellular matrix protein modifications will be happening, okay. Then there will be induction of matrix metalloproteinases that will be resulting in breakdown of extracellular membrane. Clear? So, remember this interleukins are going to increase in preterm labor. Yes, you have to also understand that there is an increased risk of preterm labor associated with Gardnerella vaginalis and urea plasma ureolyticum. Okay, but anytime asymptomatic vaginal candidal infection is not associated with preterm birth. Clear? Because this is one of the commonest infection that you see in pregnancy. So when it is asymptomatic, this need not be the risk factor for the preterm birth. Clear? Yes. Now, I said there is a relation with the genetic factors also. So genetic factors are suspected when there is a history of recurrent preterm birth. Okay. So there is a family history also. Familial recurrent preterm birth. Okay. Some of the genes include EB, F1, EE, FSCE and AGTR2. C. Gingivitis, which is a chronic anaerobic infection, okay, can be associated with preterm labor. And then we have some of the pregnancy factors also, include if she has a history of threatened abortion in the early pregnancy previously, then there is a high risk. So threatened abortion in the previous pregnancy. Okay. Then suppose if the baby has birth defects or if it is a multifetal gestation, then also the risk is increased. And the intervals between the pregnancies, when it is less or when it is more. When the intervals are less than 18 months or if it is more than 59 months, okay, then there is a high risk for preterm labor as well as small for gestational age baby. And if the mother has inadequate weight gain, then also the risk is more. Clear? Yes. Now, we will go for the lifestyle factors. So, first is about the age, definitely I want to say. So, extremes of age has a high risk for preterm birth. Okay, extremes of age means whether it is a teenage pregnancy or if she is a elderly woman. And then when there is extremes of maternal weight, okay, that is when she is underweight woman or she is a obese woman. And then her height, she is a short statured woman, and nutrition basis, if she is suffering from poverty, vitamin C deficiency especially, then if there is a history of long working hours or a personal habit of smoking, especially cigarette, okay. It does not mean that other smokings are good. So, any kind of smoking is injurious to the woman as well as for the pregnancy. Clear? Yes. Now, we will see how we are going to diagnose this. So, diagnosis includes symptoms like the patient will be presenting with menstruation like cramps, watery vaginal discharge, or low back pain. Okay, these are the most important symptoms she will be presenting to you. And even pelvic pressure symptoms also can be present. Okay, and then we will see about the cervical changes. Uterus I already mentioned you, right? So there will be contraction. Okay, when you feel for the uterus on examination, you will be having contraction. And cervical changes include, suppose there is a asymptomatic cervical dilatation, 1 to 2 centimeter after mid pregnancy. Okay, then this is considered as a risk factor for preterm labor. Okay, so usually when this kind of dilatation is seen naturally, then they will be expected to deliver within the next 21 days. Okay, and then you have to go for cervical length measurement, right? So cervical length measurement, so USG findings where you are able to see a short cervix, means less than 25 millimeter in length, is suggestive of preterm labor, and this should be done between 20 to 24 weeks. Okay, and this can even be used as a method of screening, okay, in women with high risk factors. Clear? And then suppose if that is less than 20 millimeter in length with no prior preterm birth. Clear? And also remember the fact that when the cervical length is less than 20 millimeter in a woman who has no history of preterm birth, then this is also considered as a risk factor for preterm birth. Clear? Okay. Now, how are you going to measure the cervical length? Okay. So, we are going to measure cervical length when the woman's bladder is empty, and mostly we will be preferring a transvaginal ultrasonogram, and the measurement will be done from the internal cervical os to the external cervical os. Okay. So, I have already told you that anywhere between 16 to 24 weeks of gestational age we will be doing this screening, and the length of the cervix is less than or equal to 25 millimeter, means then this is considered to be a risk factor. Okay. So, we will see some of the biomarkers that are used for diagnosis of preterm labor. So, biomarkers for diagnosis of preterm labor include fetal fibronectin, which in short is written as FFN, then phosphorylated insulin-like growth factor binding protein, okay, that is insulin-like growth factor binding protein 1. Then there can be changes in the placental alpha microglobulin 1 also. Okay, so that is placental alpha microglobulin 1. Okay, so these three markers are very important. Anyhow, we are not doing this biomarkers regularly. This is only for theory purpose. Okay, in our settings we are not doing it regularly. Okay, but this is very important for your exams, your viva, for your entrance exams, everything. Okay, so what you have to do is you have to know about this fetal fibronectin well. Okay, so if you ask me what is this fetal fibronectin, where it is present, see, this is a protein, okay, that is present at the deciduous chorionic interface. okay, and this is a extracellular protein. So, any conditions that is leading to disruption of this deciduous chorionic interface is going to cause an increase in levels of fetal fibronectin, okay. So, we can go for a qualitative or even a quantitative assessment of this protein by using ELISA, okay. And in ELISA, if you find the fetal fibronectin values are more than 50 nanogram per milliliter, then you can diagnose it as a preterm labor, okay. Also remember, there can be chances of contamination with amniotic fluid, and it will be done before 34 weeks of gestational age, when the dilatation is less than 3 centimeter and the length of cervix in TVS you have seen is between 20 to 30 millimeter. Clear? Okay. Now, we will see what is the point about the maternal fetal stress. So, when there is a maternal fetal stress, okay, this will disrupt the physiological as well as the psychological functioning of the individual. Accepted? Yes? Physiological and psychological functioning of the individual is disturbed. So, what are the causes of psychological stress? So, psychological causes of stress include depression, any history of childhood stress in the mother, and when there is a post-traumatic stress syndrome. See, also preterm labor is found to be more in black people because they have a stress of racial discrimination, okay. So, what happens due to the stress means there is a premature activation of fetal, adrenal and the placental axis, okay. So, this will bring about the contractions and it will lead to cervical dilatation and effacement, and it is going to bring about labor. Clear? Now, regarding investigations, see, the only investigation that is valid to do is your ultrasonogram to check for your cervical length and dilatation, okay. Whereas fetal fibronectin levels measurement is debated, and this is not recommended by the ACOG. Clear? And also, suppose if the woman is symptomatic, okay, she is actively going for a labor or she is having active complaints, then your placental alpha microglobulin 1 is found to be superior to the fetal fibronectin. Clear? Anyhow, we are not doing all these tests regularly in our country. Clear? Yes. And sometimes one additional investigation you can offer is urine culture test to rule out any asymptomatic bacteriuria. Okay? Yes. Then we will pass on to the preventive measures. Preventive measures include cervical circlage. Okay, so this can be provided in the following indications, including when there is a history of recurrent second trimester abortion, or you are able to see a short cervix in a TVS examination, and then when there is threatened preterm labor. Okay. So, cervical circlage has brought improved outcomes in pregnancies where there is a single fetus and the cervical length is less than 25 millimeter and the gestational age is less than 24 weeks. Okay. So, I told you the cervical length we have to measure from the internal os to the external os. Okay. Suppose internal os is open means what we will be doing is this is open. Okay. So, we will be measuring from the tip of the internal os to the external os. Okay. And we also know that the cervical length changes are seen in the form of letters. First it will be T-shaped cervix, then it will change to Y-shaped cervix, then it will become a V-shaped cervix and then it will become a U-shaped cervix, that is when it is completely opening up. Clear? I will just show you the pics, but for now just look at the ultrasound picture where you have the fetal head over here. Yes, this is the fetal head and you are able to see the funneling of the cervix. Okay, as the cervical os is opening up, one end is yet closed and the other end is trying to open up, so it will appear just like a funnel. Okay, so that is funneling of cervix. And you have the anterior cervix, posterior cervix. This is the internal os that is opening up and there is some sludge collection that is seen. Okay, so this is seen like a hypoechoic matter, hyperechoic matter. Okay, that is deposited in the cervix. Okay. Now, this is what I was trying to tell you. So, as the cervix is opening up, see normally it is in the shape of T. Okay, I will draw this over here. So, you will be able to see this is in the shape of T. So, this is normal. Now, as it is slowly opening up, see this becomes in the shape of Y, then here it is in the shape of V, and when it is completely opening up, I am able to take a shape of U. Clear? So, this is how the changes will go. Okay. So, we can go for cervical cerclage, okay, when you detect cervical incompetence. And then most important documented method of medical treatment, okay, in this woman is progesterone therapy. See, what is bringing the menstruation as well as what is bringing the labor? It is progesterone withdrawal. That factor you should remember. Okay. So, if progesterone withdrawal is going to bring about labor, when preterm labor is happening and I just want to prolong the pregnancy, what I should give them? Progesterone. Yes. So, that is why we are giving progesterone therapy. But remember, this is given only in cases of singleton pregnancies and when the other causes of preterm labor are ruled out. Clear? Okay. Now, what are the progesterone supplements you can give? Okay. So, we have two kind of supplements, that is 17 alpha hydroxyprogesterone capriate, that is given as a 250 milligram IM injection weekly. Okay, and this should be started between 16 to 20 weeks of gestational age and continued till 36 weeks of gestational age. Clear? Or another option of supplementing progesterone is a vaginal micronized progesterone, that is given in a dose of 100 to 200 milligram tablets daily. Clear? So, these two options we have. Clear? So, next we will see about how we manage preterm labor. So, management of preterm labor includes three main interventions. Number one, we have to supplement them with antenatal corticosteroids. Number two, we have to give them tocolysis. Number three, we have to give drug for neuroprotection. Yes, which drug you will give? That is magnesium sulfate. Clear? These 3 points should be taken care while managing preterm labor. Now, first we will see about the corticosteroids. You have to administer a single course of antenatal corticosteroids between 24 to 34 weeks of gestational age. Okay. So, between 24 and 34 weeks of gestational age for at-risk women. Okay. Here, when you give this, the neonatal mortality rate will be reduced to 50%, and there is a decrease in incidence of respiratory distress syndrome, intraventricular hemorrhage as well as necrotizing enterocolitis in the infant. Clear? So, how does this corticosteroids work? Now, corticosteroids are going to accelerate the development of the pneumocytes, okay, both type 1 and type 2 pneumocytes, and then there is an induction of the pulmonary beta receptors, then it will also help in releasing the surfactant. Okay. So, what are the common drugs we will use for corticosteroid administration? So, drugs used and the doses include, we can use betamethasone, yes, 12 milligram IM, 2 doses, 24 hours apart, and then we can give dexamethasone 6 milligram IM, 4 doses, 12 hours apart. Clear? You can also administer a rescue course, that is nothing but a repeat dose of the whole course of administration of corticosteroids if the woman hasn't delivered any time after 7 days of administration of corticosteroids, or if it has taken more than 14 days, the pregnancy has prolonged more than 14 days after the administration of the corticosteroids. Clear? 7 days and after that not delivered, and 14 days prior the last course was taken. Clear? Now we will see the tocolytic drugs. See, these are drugs that inhibits and even stops the uterine contractions. So, they inhibit and stop the uterine contractions. This is given for at least 48 hours, okay, for short term prolongation of pregnancy. Because there are 3 important points to consider to administer tocolytics. Number 1, we can administer Maxilf in this period for neuroprotection. Yes, we can administer antenatal corticosteroids whose use I have already discussed, and then we can even transport the mother to a higher facility if needed. Okay. Now we will see what are the drugs for tocolysis. First drug is nifedipine. Okay. See, nifedipine is a calcium channel blocker. So, this is a calcium channel blocker. You will be giving 30 milligram loading dose orally, followed by 20 milligram every 8 hours for 48 hours. Understood? So, we will be giving a loading dose of 30 milligram, then every 8 hours we will be giving 20 milligram, and that should be continued for 48 hours. Clear? See, this is one of the most common drug that is used for preterm labor. And while giving it, do not give neuroprotection with Maxelf simultaneously. So, do not administer Maxelf simultaneously because it enhances the neuromuscular blocking effects of magnesium. Okay. And what are the side effects that you can see with this drug? Okay. Side effects of nifedipine include flushing, headache, dizziness and palpitations. Clear? Okay. We will see the next drug, that is terbutaline. See, terbutaline is a beta adrenergic receptor agonist. Okay. This is given as a dose of 0.25 milligram subcutaneously every 20 to 30 minutes, and this can be given up to 4 doses. Okay. And this will be followed by 0.25 milligram subcutaneously. If the labor pains has decreased, this can be changed to from 20 to 30 minutes to 4 hours once. For 24 to 48 hours we have to continue. Clear? Yes. Now, what are the side effects that are seen with terbutaline? You will have tachycardia, palpitations, hypotension, and in the neonate also you will have hypoglycemia or neonatal tachycardia. Clear? Yes. And then we will see about the next drug, that is indomethacin. See, what is indomethacin? It is a non-selective cyclooxygenase inhibitor. So, it is a non-selective cyclooxygenase inhibitor. We will be giving a loading dose of 50 to 100 milligram either through oral or rectal route, and this will be followed by 25 milligram of dose orally every 4 hours. Clear? Yes. Now, maximum duration will be using this drug is also up to 24 to 48 hours, because what are the side effects you can see with this drug? There can be chances of oligohydramnios, necrotizing enterocolitis and closure of ductus arteriosus. So, for the fear of this risk, we are not using indomethacin after 32 weeks. So, after 32 weeks, if preterm labor is happening, don't ever think about indomethacin. Clear? Yes. Next drug is atosiban. See, atosiban is a nonapeptide and this is a oxytocin analog. Okay. Also, this is a oxytocin receptor antagonist. Okay. But the use of this drug is denied because there are so many adverse neonatal outcomes seen with this drug. Okay. So, atosiban is nowhere used now. Okay, but even then you have to know this one point, atosibin is a oxytocin receptor antagonist. Clear? Yes. Next one is about magnesium sulfate. See, magnesium sulfate is given for neuroprotection, but at the same time it is also acting as a calcium antagonist, which makes it a tocolytic also. Clear? So, it is also a calcium antagonist. Okay? But it is ineffective in this mode of action as a tocolytic, and even this can be considered as a potentially harmful drug when used for protection of preterm labor as a tocolytic. Okay. So, because when you use it for a prolonged time, so prolonged time use can lead to bone thinning and fractures. Okay, because why? It is a calcium antagonist. So, there will be low calcium levels in the fetus also. That will be leading to fractures in the fetus. Clear? Yes. Now, what are the contraindications generally for using any type of tocolytic? Okay. So, contraindications for tocolysis include, yes, intrauterine fetal death is there, we shouldn't be using tocolysis. Then when there is preeclampsia with severe features, we shouldn't give tocolysis because we have to terminate the pregnancy as soon as possible, right? So, in that case there is no use in prolonging the pregnancy. That will even exaggerate the symptoms of preeclampsia, right? So, there we are not going to give tocolysis. And when there is a lethal fetal anomaly, okay, suppose anytime she comes without having done her basic scans like anomaly scan and all, and you find a major anomaly that is seen in the fetus, then you will be giving tocolysis and you will be saving the baby, but that will put her into more psychological and financial stress in the future. So, anything if you find like major fetal anomaly, we are not going to give tocolysis. Okay. Then if there is a chorioamniotic infection, okay, chorioamniotic infection, we are not going to give tocolysis, and if she is having a hemorrhage also, we shouldn't give tocolysis. Sometimes when speaking about hemorrhage, I want to add one more point here. So, sometimes the women in preterm labor can also come with bleeding PV, right? That time, before doing a per vaginal examination, just rule out the placenta previa. Okay, don't ever forget this point. Okay, yes. Now, we'll see how magnesium sulfate is given for neuroprotection. So, magnesium sulfate for neuroprotection is given when you anticipate birth at less than 32 weeks of gestational age. Okay. So, magnesium sulfate, it reduces the severity as well as the risk of cerebral palsy in the newborns. Okay. So, how you will be giving? You will be giving it as a 4 gram IV bolus dose, that is loading dose of magnesium sulfate, that will be followed by IV infusion of magnesium sulfate at the rate of 1 gram per hour. So, the dose of magnesium sulfate is given according to the Zussman regimen, okay, just like Zussman regimen. So, we will be giving a 4 gram IV loading dose, and this will be followed by 1 gram IV per hour of Maxilf that will be given as a IV infusion, and that will be given for 24 hours. Clear? Yes. And don't ever forget to monitor for the toxicity signs of Maxilf when you give neuroprotection. Okay. Next point is how we are going to plan delivery. See, delivery planning is simple. When it is in a cephalic presentation, you go for vaginal delivery, and cesarean section is indicated when it is a breech presentation, FGR, or any other obstetric indications. Clear? Yes? I hope you'd have understood preterm labor. So with this, we are finishing this discussion. Until we meet in the next video with a new topic, take care, happy learning, and bye-bye.